I'm Norma Coe. I'm a professor at the University of Pennsylvania, but very excited to spend the year visiting LSE this year. I focus primarily on the USA. I describe my work as worrying about how we're going to provide and how we're going to pay for care once people cannot live by themselves independently. So I've done work related to how to value family care or informal care, how to think about what are the benefits of having family involved in care, also from nursing home care, and how do we think about how much family is involved in nursing home care and measuring that in the U.S., as well as how to fund long-term care between a Medicare program, which doesn't actually cover long-term care, but it is our health insurance for older adults, and the Medicaid program, which is our health insurance for individuals who are relatively poor, but does cover long-term care. Very few benefits of the pandemic is that long-term care is actually getting some attention again. I don't think it's enough still. So far, there was a lot of proposals that were in the Biden Build Back Better plan right after the pandemic, but most of them did not get passed. The one that did get passed is staffing regulations in nursing homes. They have become a law, and we will see if they are repealed shortly. I unfortunately do not think that that we have rebounded from COVID to the point where we can actually say that we are in a better place yet. Hopefully there's enough policy momentum that we can get there, but I don't think we are there yet. I think we really need to be taking a serious look at a wider spread insurance policy than what we have currently. I think that there's a lot of distortions in the economy because of our lack of insurance, and we really need to be sort of capturing those labor market effects in different ways that long-term care insurance could actually bolster the economy. I think we need to be thinking about the provision, both in terms of staffing and professional staff, but also really thinking about family caregivers who, like in most countries, provide 80% of the long-term care. But we do very, very little to actually support them. We have some payment programs, but not very well developed yet. Mostly it's not integrated between long-term care and acute care. So we even have a different health insurance system, as if the Medicare program is health insurance for older adults, but it does not cover long-term care. Medicaid is the primary payer for long-term care in the U.S., and that's for poor individuals. So there is some integration. We're trying some different payment models there. We call them ISNPs, institutional special needs plans. But it's really underdeveloped, I would say. So there's been a growth in some of these special need plans and trying to coordinate between Medicare and Medicaid, but I would still say we're at a relatively infant stage in both understanding what works and understanding how to sort of spread it more widely. My personal top priority would be to introduce long-term care insurance with a very flexible benefit package that could include things like paying family members and not make it tied to income or means, make it much more widely available to try to get in some political buy-in so that it would actually pass. So I think that there's a lot of research out there that does show that having long-term care insurance and having a stable workforce could lead a lot to, or could contribute a lot to better long-term care and better outcomes for patients, better outcomes for caregivers. There's always room for more. And I think that from a political standpoint, we're always looking for the ROI, return on investment case. But I think that there's a lot of evidence already that says that having stable workforce, both formal and family care, and supporting them does lead to better outcomes for everyone.